दुआएं दिखती नहीं लगती है. ગાંધી જયંતિના દિવસે શરૂ થયેલા આપણા કાર્યક્રમને માટે આપણે સૌ સાથે મળીને આ બધા જ આપણા મહેમાનોને વધાવી લઈએ. 22 વર્ષથી હૃદયરોગના પાયાના ઉપચાર અને જીવનશૈલી માટે એમણે જે જ્ઞાનનો લાભ આપ્યો છે એ ખરેખર વખાણવા જેવો છે. રમેશભાઈએ 22 વર્ષ પહેલાં જોયેલું સ્વપ્નું અને ડૉક્ટર કોકિલાબેનની મળેલી સ્ટ્રેન્થનો આ લાભ કાર્યક્રમને ખૂબ સફળ બનાવી રહ્યો છે. મનોબળ મજબૂત બન્યા, સંકલ્પ બળ પ્રબળ બન્યા, વ્યક્તિ પ્રાણવાન અને શક્તિશાળી બની. So it is our proud privilege that Vasantbhai Mehta, જેમણે
not going to read about Dr. Tuzu because it has been, all over Dr. Tuzu's introduction is there. But I want to tell you something about Dr. Tuzu in a different way. Everyone has known about his stature in the Cleveland Clinic, and everyone should know that the Cleveland Clinic is now a #1 heart center in the whole world. But that's not the point. He is much more than that. And that is why I have invited him. And I'm so grateful that he has accepted our invitation. He is what I would like to see in a real cardiologist. I never wanted to become a doctor because I thought, well, I'm not cut out to see the ill people and all illnesses, and I was not cut out to even dissect a frog and study the systems. I became interested in medicine only when I studied in UK and came across my teachers in cardiology. And when the heart came, it had already come to me when I met Kokilaben, but that was a heart in a different way. But then it also then added up when I really learned about coronary heart disease. And Dr. Tuzu, in spite of his technical skill, he can place a valve through the catheter. He can place a valve through the catheter without surgery. And he's doing it absolutely perfectly, and he's known all over the world for that. He can do, of course, angioplasty and all that. That is very common for him. But above all, according to me, he's a real cardiologist. Now, who is a real cardiologist? Who knows heart. And you see, the heart, to know the heart and heart so well and love your patients, that is what I found in him the most. And that's why I respect him. And I came very close to him through my son, and that's why he's here. Now, with that introduction, I don't think I should talk about universal healing and coronary heart disease at this point, because enough will be said by Dr. Tuzu in prevention and treatment of heart attack. I only want to make one point, that coronary heart disease, according to me, it's not a disease. Disease is something which is connected with all the ailments, while coronary heart disease is something every human being born on this planet may have at one time or another, and it is one of the finest things to have. Not nice to have at a very young age and die of it, of course not. But it is as I have said in my lectures many times, that all said about the coronary heart disease, that it occurs in people who smoke, who are overweight, who have got this and all that. But I don't tend to agree to that. It does occur. But it occurs in the most virtuous people. People who are absolutely perfect in every way. In their height, weight, in their manners, in their behavior, in their respect in the society, for being a very good man, and all the virtues of the heart, all the virtues of the heart. And if you have all the virtues of the heart, you can have only one illness when you turn about 60. And you can say that, oh, I have never been ill in my life. I have never seen a doctor. I've been absolutely hale and hearty. Look at me, I've got, whatever you tell me, I've got everything what you call merits. But that merits multiplied 1,000 times, and you can get a heart attack. And this I can tell you from experience of 50 years, that most people I have seen having a heart attack who have come and told me, Doctor, why I got a heart attack? And I tell them, just because you are a human being of a very nice nature, and you have got a real heart, therefore you got a heart attack. And I don't know whether he would agree with me, but I have lived through this history of coronary heart disease for the last 50 years and more. And I have been working with the topmost heart specialists of the time in those days, in 1960s. President Eisenhower, Dr. Paul Dudley White, he treated Eisenhower with love, with treatment, which we are doing now. And he had two terms of presidency after heart attack. And Paul Dudley White is known all over the world for the way in which he treated them. And he started the Framingham study, which is still going on, why people get heart attack. So I have got such memory. See, first 20 years of my career in Ahmedabad, first 20 years, there was no angiography. There was no angioplasty. Nothing was there. And I was lucky. I settled down as a cardiologist quite early in my career. Within 5 years, I was quite busy. I treated the most VIPs of this town. Even I was requested to see Kasturbai. I visited him 3 times. Dr. Sumanbai Saab was his senior physician. But I had done my MRCP in cardiology, so the doctor said, we'll call somebody who has just come with the highest qualification. I met him. And like that, so many VIPs I met, and I treated them. And I treated them to be great interest. I treated them at home. But at that time of my practice, there were homes. Now there are no homes. You see? I could admit, when I took one of my patients, a millionaire of the city, and I took him in to Denton Cooley, because he said the president goes to Denton Cooley, I also want to go to Dr. Denton Cooley. I said, why? Well, you are all right? No, I want to meet him. So I took him. He was already under my care for 17 years. And I took him there, and he met Denton Cooley, and Denton Cooley said, why have you come to meet me? So I told him that he wants to see whether he can be benefited by bypass surgery. So Dr. Denton Cooley laughed and said, I do bypass surgery, but I don't decide whether you need it or not. My physicians decide. And what does your physician think? So I said that I don't think he requires, he's under my care for 17 years and he's all right. Okay, it's your physician. Now I'll give you 3 physicians like your physicians who are in my clinic, and 3 of them, my secretary will get you an appointment. And if one of them or somebody tells me that you need bypass surgery, I'll do that. So he was examined by 3 senior physicians at that time. This is around 1978 or 1979. And all the 3 of them saw him, one by one, said and all that. And they said that, I don't think Mr. So-and-so, I don't want to tell his name, Mr. So-and-so, you will benefit by bypass surgery. So we had deposited at that time $22,000 for the surgery to Denton Cooley, because we have to deposit before you meet him. So he said that keep 3,000 for me and take the rest and please go, because you don't require bypass surgery. And then he lived for another 15 years and died in sleep one day. So I have been, and so many people I treated, they all went. Because the natural healing, as I told you, And there I'm going to stop today. I'm not going to go at all because I'm going to give a lot of opportunity to Dr. Tuzu to talk to you. That, you see, the point I wanted to make was, something was very interesting. Need to slip my mind. Anyway, what I'm trying to tell you is that once the person gets a heart attack, that's my teacher I remember. My teacher I remember with great respect. Every time I see a patient, when I used to see before, now I don't see the patients. Now I only see the people who are completely healthy, but they are afraid, and they have been told that you must get a bypass done tomorrow. And they come to see me after 1 month of heart attack or 2 months of heart attack, and they wait for me for 1 month for appointment. They wait in my clinic for 1 month. So even a most ordinary doctor can decide that they don't require bypass surgery. And I tell them that you don't require it, and they all do very well, and I know what treatment to give and all that. But anyway, my teacher, and I remember him today with great gratitude. When I did my MRCP, and it was considered the highest qualification at that time, when I was coming home, I was going to United States for further studies. He said, doctor, you have got the highest qualification. Now I want to tell you only one thing, and remember that. I don't want to tell you anything. You have been a very bright student, you have done very well, and you are now going to United States to a very good doctor. He's also a physician to the President Kennedy. But I tell you one thing, and it is a very simple thing he told me, that when the person of heart attack will come to see you, he will not come to see you immediately after heart attack because you're going to be a consultant. So he might see you after 6 hours, 8 hours, 12 hours, or after 2 days even, for your opinion. And therefore, if he's alive, then only he will come to you. So then remember that if he comes to you like that, he is going to be alive. He has come to you alive, and he is going to be alive. Remember that. And with that confidence, I treated all my patients from the very first day. And then I knew how to prevent another heart attack. And therefore, that first tenet, which I keep on telling, doctor's confidence in himself that he is going to cure the patient. First tenet of Tibetan medicine. And that really, that came afterwards. But my teacher taught me, and I got it somehow. Because I've always been very successful with heart. So again, I succeeded there. And all my patients, I'm very happy to tell you, and everyone knows in the city, they all did well. They did not die because they were alive. And I treated them, explained to them what to do, and I was confident. And one by one, when I succeeded, I developed more and more faith. So everything turned out to be a very, very happy cycle. Okay, as I promised, I'm not going to talk more. And Dr. Tuzu is going to enlighten you in a very, very great way, I can tell you. And therefore, I'm not going to stand between you and Dr. Tuzu any longer. Again, I thank all of you for every time to receive me with great joy and affection. And that has helped me, and that has kept me young, in spite of my strong family history. And I'm again very thankful to you, and I really bow down with all my respects to all of you. Thank you.
Thank you, Dr. Ramesh Bhai. I will request Dr. Murad Tuzu to deliver his address to prevention and the treatment of heart attack.
Well, I am honored and humbled. Dr. Ramesh Kaparia's son, Dr. Samir Kaparia, came to Cleveland Clinic in 1990s. He was my resident. He worked with me very, very closely. From the first day on, I was very impressed, very, very impressed with this young man, and then promised that I will never let him out of my sight, except for a few years. I did not, and then he's now my closest colleague and very, very close, my closest friend. Now, after I met his father, I realized and learned more about his city, his state, and his culture. I appreciated where this brilliance, humanity, an extraordinary humanity really is coming from. By that time, through Dr. Ramesh Kapadia, I was introduced and educated a little bit about Mahatma Gandhi and what it meant to this society and what it meant to this whole world, to all of us. And really it was a unique experience. And this morning I was fortunate enough to spend some time with Professor Iyengar that took me around and gave me even more insight about the Gandhi philosophy. And I think that there are a lot of things if we listen and if we try to learn that will make us better physicians, better healers, and better humans, of course. With that education and with that insight, I am deeply thankful to Dr. Kapadia and his colleagues and to my friends now, many of them that I met today, and to all of you to give me this privilege. So I'm going to give you an idea of what is coronary artery disease and how it becomes a disease, and what do we do, how do we approach. And I'm going to tell you that story not as a classic textbook sense, but as a practicing physician as I'm talking to my patients. Now, heart supplies the blood to the whole body. The organ that receives the blood first is the heart itself, through 3 blood vessels. They are called coronary arteries. Artery means blood vessel that carries the oxygen-rich blood. The veins are the blue blood carriers. The arteries are the red blood carriers. Now, I'm going to just pause a little bit and tell you, just because I'm going to show you the structure of the blood vessels, the coronary arteries, how we get that information. We get that information through what's called coronary angiography. I'm showing this to you so that you get familiar with the morphology, with the concept. We either go from the groin or we go from the wrist and go up to the heart and give dye and take picture, just like this. On the left-hand side, you see the coronary artery or the blood vessel that is one going to the front of the heart, called LAD. The other one is to the side of the heart, that's called circumflex, and so you see the arrows that's indicating that. And the one that's going to the back of the heart and the bottom of the heart is called the right coronary artery. And now, if these get narrowed, just like here, you see that in these circles corresponding to that angiogram, that is coronary artery disease. Now, it depends on where the blockage is that determines how much the heart is going to suffer from inadequate blood supply. This is the idea. This is not complex. This is really, I call myself a plumber, because we deal with pipes. Now, let's try to understand how the coronary artery disease occurs. Coronary artery disease, we start our lives with a very clean blood vessels. That the blood flows, together with the blood, a lot of particles, a lot of nutrients, a lot of fats flow through. Now, when the layer of the there we go. Let me see if I can show you. Here we go. Now, when the layer get a little damaged in childhood or teenage years, the bad particles, the cholesterol and other bad actors, go underneath the surface of the blood vessel and form this plaque, form this atherosclerotic plaque. Very small. Nowadays, over the last 20 years, we are able actually to see what is going on at this very early stage by putting tiny wires inside the blood vessels equipped with an ultrasound. So that a tiny blood vessels, a wire, as you see at the left upper side, and on the screen we can see the cross section as if you took a loaf of bread and sliced. Blood is flowing, and in between the yellow area is the plaque. So as you see, I'm cutting a loaf of bread and then looking at the cross section. I can see even the tiniest piece of atherosclerosis. There's 1/10 of a millimeter, I can detect that. Here is an angiogram, here is a pipe. I can go to a point where I can diagnose or look at by looking at the cross section. And I can look at another branching point, and in between, as I move my wire back and back and back, every millimeter I can examine. So I am looking, as if you will, the entire bread loaf by slicing it by every millimeter. So I'm getting a very good idea of what's going on in the blood vessel. So with this technique, I can look at a coronary artery here on the left-hand side that looks normal, but when you look inside, there are a lot of abnormalities. As a matter of fact, with Dr. Samir Kapadia, I have looked at these in many, many young, healthy-looking hearts from age 12, 13 to 50, 60. And this is a graph. I'm not going to show you a lot of medical data, but I think this is important. Look at this graph. In people that are younger than 20 years of age, there was clear evidence of the hardening of the arteries or atherosclerosis is 17%. What that means is 1 in 6 teenagers had the seeds of coronary artery disease, had the seeds of the heart disease. So coronary artery disease is not a disease of adults. It's a pediatric disease. We don't see it. We don't appreciate it. It doesn't cause symptoms, but it starts childhood. So when I'm talking to you, I'm not only pleading with you to take care of yourselves, but start taking care of your children, start taking care of your grandchildren, start taking care of your babies, because that is where really the battle can be won. Not after a year of age of 40, 45. The battle can only be won if we start this thing with the childbirth and even in the womb, when the baby is in the womb, because we know that we are affected. Let me not take you back with this information and explain to you in another way. Well, I'm going to make an analogy and come back to that analogy on and off. Think of a 3-lane highway, very nicely paved, beautiful asphalt, no bumps, no holes, nothing. That's what our inside of our blood vessels look like when we are born. Nothing. Then as we grow up, depending on how much we walk and play in the garden, or how much we eat unhealthy food, if we smoke or not, if we have bad genetics, and many other things, we get these little bumps on the highway. No problem. Just like many of the streets that I traveled over the last 24 hours, it certainly doesn't obstruct the traffic. Very important. There is a problem, but it doesn't impair the blood flow, the traffic. Now, let me go back to this picture and make the connection. What happens is the artery starts to get filled, and as you see here, part of the blockage push the whole way outside, you know, the tunnel out. So it preserves at least 1 lane, 1.5 lane. Should we go ahead? Oh, I'm sorry for this 1 second. Well, I'm not sure, because we don't know if the traffic on the street out there, despite the fact that 1 lane is closed or 2 lane is closed, is not flowing or not. We have to figure that out. That's the critical element. Now, one day a sudden growth in that area, just like here, may block the 2-lane traffic. Well, is it impeding? Here you see, I make the same analogy. There are bread trucks, the trucks that are bringing bread to the small village on this highway. Now, 2 lanes are closed, 1 lane is open, but the people are happy because they are getting what they demanded. There is enough supply to the demand. Why do I have to do anything? Don't forget, if I try to fix this highway, I have to spend a lot of money. There is possibility that the contractor is not very good. He said that he'll finish in 2 days. It takes 20 days. And then when he finishes, it may be worse than when you started. So be careful when you are making a decision. Well, what I would do is do a stress test, see if I can create an environment that the demand increases to see if the supply matches the demand. So when they say that in that little town or village there is a holiday, that there are a lot of people, 2 or 3 times more people waiting for bread coming from the city. Well, then we will know if it is in this case, if it is like this case, that people started to scream from hunger because there is not enough bread coming through the highway, then I think you have a problem, you have to fix this. Put a stent, do bypass surgery, because large amount of people are in jeopardy of starvation. On the other hand, if despite the blockage, despite the increased demand, the supply is maintained, the stress test is negative, there is no demonstrable evidence of large areas of inadequate blood supply in the heart, why would I do anything? That's what Dr. Ramesh Kapadia is telling you. I can treat this, I can take care of this, even though there are blockages, you don't necessarily rush into doing bypass surgery or stenting, which as somebody who makes his living, who earns his living by stenting, is telling you that is correct. So the idea is to focus on the demand-supply ratio and how large an area is in jeopardy. How big is the town? How many people in the town is suffering? If you have a town of 10,000 people and it's only 20 people, maybe you have to find other ways to take care of that. But if you have, after 10,000 people, if you have 4,000 people that's in danger of starvation, that's a different story. You have to do something about that. Here you see that. Is there an inadequate blood supply? Is there, if there is it large? Is it on the left-hand side? Or is it a small area? Is it on the right-hand side? And these are not just opinions. We have looked and observed many thousands of patients, compared people who had small and large area of inadequate blood supply in the heart, followed them for 5 years, 10 years. We know that medical therapy works as well as anything else, even better in many times. Now, again, I see in the United States, probably my colleagues see in here too, and some of you were subjected to tests that look at take a photograph of the highway. One of them is this computed tomography. It's called virtual angiography. There's widespread. It's a wonderful tool, but it is very open to be misused. But let me show you. Here is a patient that had a narrowing that was told to have a stent placed. When the patient asked, what percentage of my blood vessel is narrowed? You know, you hear this 70%, 90%, 99%. Well, if you take this angiogram, and these are all scientific data, if you take this angiogram and show to one cardiologist, he will say it's 80% narrow. Next one will say 60% narrow. Next one will say 70% narrow. So there's a tremendous variability in visual estimation. Okay, let's do it. Computerized calculation. When you did the computerized calculation, it is 58% narrow. But it still doesn't tell us if the trucks carrying the bread loaves are getting through the town adequately or not. Okay, so that is the critical element. Let me show you an example, a case example. 55-year-old man had a CT scan for checkup. Then they found a blockage, then they said, let's do a coronary angiogram. He was told he has an 80% narrowing in the artery supplying the front part of the heart, but he has no complaints, no chest pain, no shortness of breath. He is overweight. He leads a sedentary life. He has high blood pressure. Cholesterol levels is unknown. Hasn't seen a doctor. Still smokes. Here, instead of this patient with no symptoms, you can put a 55-year-old, 60-year-old, 65-year-old man who has occasional chest discomfort when he climbs 2 flights of stairs. Should he go and have a coronary angiogram? And should he have a stent placed right away? Well, I don't think so, because I think that we know that there is 2 types of coronary artery disease. 2 types of coronary artery disease, how it is presented. If I had the opportunity to look at this patient's coronary artery, to look at this patient's blood vessel, what I will see, indeed a narrowing, but the fat-filled plaque is separated from where the blood flows with a very thick cover. We call it a cap. And these are generally very stable patients. We call this stable coronary artery disease, so this is one type. The prognosis with proper medications is very good. The prognosis cannot be improved by bypass surgery or stenting. You can't make these people live longer or have less heart attack. This is stable coronary artery disease. The same angiogram, that we see here of a different patient. 55-year-old man developed chest pain and shortness of breath. In a week, symptoms progress in intensity and frequency. He came to the emergency room after waking up in the middle of the night from his sleep with chest discomfort and sweating. They took an electrocardiogram, it's abnormal. A coronary angiogram was done. This is an entirely different picture. This is a very different disease. This is called acute coronary disease. When you have a heart attack or an impending heart attack, as is this man. And if I had the opportunity to look at the heart carefully, what I would observe is that cap, that barrier between the fat-filled plaque and where the blood flow is disrupted, is torn. There is a tear there, there's a rupture there. So when the blood saw what is going on in the wall of the artery, those ugly fat, cholesterol, all kinds of accumulation, it started to react and then form a blood clot there. Then you have to do something about this. You have to get in there, open it up, give medication to dissolve it, put stents in, if needed bypass surgery. That is very warranted. So the point that I'm trying to make to you is that these techniques of bypass surgery and then stenting are wonderful tools, life-saving tools, if it is used just like many other things in life, in the right time and the right place, appropriately. Now, I'm going to show you how that rupture occurs, just to recap this acute problem. Remember, the artery grew like that, and one day, this angry plaque starts to release some substances that digest that wall, digest that cap. And suddenly, that cap ruptures. And when it ruptures, the blood reacts by forming a blood clot. And when it closed, that is when the complete big heart attack occurs. Sometimes it doesn't obstruct completely. Patient has a lot of chest pain. Doctors say, oh, you didn't have a heart attack, but you were close. But at other times, you don't even feel it. The body heals. That narrows the blood vessel a little bit more. So what is going on underneath is not one disease. So how can we treat this disease same way, however the patient presents? So that's why you need a wise doctor to make the decision by talking to you, by understanding what you are going through and explaining to you what your current status is and what the options are. That's why I think that we're putting the patient at the center of this interaction rather than the physician being the authority and the patient being the obedient person that's almost subservient to the physician. That's a change in paradigm that we had and enjoyed as physicians for centuries, maybe millennia. That is when there is an acute problem, that's when the angioplasty and bypass surgery is worthwhile. But don't forget, when we do stenting, merely what we are doing is doing a repaving of the problem area on the highway. The rest of the area is not touched upon, as you see. The rest of the problems on the asphalt is not touched upon. Same thing with bypass surgery. With bypass surgery, is very similar to the streets on the today what I saw in Ahmedabad, that people go around and find little roads around from the blockage, right? That's what's going on. But a few months later, a few years later, there is no guarantee that the other parts of the highway system will not get into trouble because there are seeds there planted. So if you don't attend to your asphalt, if you don't attend to your highway, make sure that there are no floodwaters on it or very heavy vehicles, or you don't, have people come and dig there, you will have the same problem. So the point is, When you have a traffic jam, it is imperative you do whatever it takes to clear the traffic jam. But you also should be wise enough to make sure that that's a wake-up call for you. You take care of the rest of the asphalt so you don't have recurrent problems. That's what Dr. Kapadia is telling you about. Because people coming to Dr. Kapadia after a heart attack, the problem is not the place that they had the heart attack anymore. They had that heart attack. The issue is the rest of the tree that he's taking care of, preventing them from having recurrent problems. Here is another example. Management of only nerving versus the entire atherosclerosis. Here you see this in this tree very clearly. It's only one part of the highway system that serves the town. Now, how well are we doing and where do we stand? Now, a little bit heavy science at this point, but this is not really directed to medical people necessarily. I prepared these graphics for you, so just work with me here. This is a slide that shows, this is recent data, that shows the risk factors in heart patients around the globe. We're not talking about 50-year-old healthy people. We're talking about people who had heart attacks or strokes. Let's see. Still, and I want you to look at Asia because this is predominantly India. 41% of those people have diabetes. 80% has hypertension. More than half of them had abnormal blood lipids after they had the heart attack, after they had the stroke. Now, if we attend to that, that would be a different story because I want to show you what difference it makes. In a 6-year follow-up of about 350,000 people. Can you imagine? 6-year follow-up of 350,000 people. If the person is not smoking and doesn't have a high blood pressure, this is a small diastolic blood pressure, look at the percentage of risk of dying from heart disease. You don't need to look at the numbers. And below are at different points of the cholesterol level. So it's a three-dimensional. Cholesterol level, blood pressure, and smoking. If I just add to this blood pressure, look at the risk increases. You're smoking, and then the blood pressure as your cholesterol level increases. If I add to this smoking, but no blood pressure, see how nasty is smoking? It increases further. If you are smoking, if you have a high blood pressure, and if your cholesterol goes up, look at what happens. So there is no doubt that what Dr. Kapadia is doing is not magic. There is a little bit magic, but most of it can be explained solely based on this graphic. If you get somebody convinced and stop smoking, if you control their blood pressure, if you control their cholesterol level, look where you're going to get their risk all the way from the right-hand side, the green bar, all the way down to the pink bar on the left lower side. So I think there is something here. How about eating? You know, I enjoyed the Indian food the last 24 hours, certainly. There are a lot of healthy elements, but I can't say that it's 100% healthy. Now, there has been a comparative study. This is a controlled study. So half of the people who had heart attacks in this study were allocated to eat what is called Mediterranean diet, essentially plant-based, you know, a lot of legumes, a lot of fiber, much less animal fat and much less saturated fat, and the rest is regular diet. Just that difference in this two large group of people. Look at the difference. At 5 years, one of them is about 70% alive. In the other group, it's almost 85% alive. So what you eat will determine to a degree if you are going to survive after heart attack for a long time or not. This is a scientific data. Here is another three-dimensional picture. If you engage in an active lifestyle, you move from the right-hand side, the angry-looking red bars, toward the green bars. And if you improve your body composition from high in fat to normal in fat, then you will lower your these are all scientific data that will give you the impression of how what we call the medical therapy works. This is a very interesting data. This is from Britain. They looked at, in Britain, after the Second World War, the government charged Dr. Dole and others to say that you have to think about this smoking issue. So they said, well, the only way to think about the smoking issue and its impacts is to be able to follow people who are smoking. But it's not easy to follow people. So they said, well, physicians are registered. We know where the GPs are. We know where they practice. We can always track them. And many of them smoke. And indeed, many of them smoking. So that they followed the physicians, 34,000 of them, for 50 years. 50 years. Who died, who stayed alive. You know what? People who continued to smoke lived 10 years shorter than those who did not smoke. Now you tell me another chronic disease that cuts your lifespan by 10 years. Just think about where you were 10 years ago and died that day, what you were going to miss. 10 years. When I saw this data, I couldn't believe it. This is data coming from very respected investigators in Oxford. Well, I'm going to put you to sleep decidedly by these graphs, but I think it's worth to show that this graph shows how good we physicians, the medical establishment, is taking care of all these risk factors. Look at that. Patients who had heart disease, heart attack or stroke, elevated blood pressure. And I want you to look at this purplish Asia, the 2, 4, 6 bar. In Asia, India is in there and the predominant country, 52% of people with heart disease do not have their blood pressure well controlled. That is unacceptable. That's almost bordering criminal. These people are not just like screening and found to have blood pressure elevation. These people are already had heart attacks, already had damaged hearts. 43% of the Asians did not have adequate blood pressure, cholesterol control, and 13% are still smoking. Now, this is very recent data from Dr. Salim Yusuf, a very renowned and very deserved prestigious Indian physician that's practicing in Canada. And this data coming from low-income countries, and India was counted as low-income countries and participated in this study in a large number. Again, healthy lifestyle changes. We are not even talking about medication for cholesterol, medication for blood pressure. Look what shape we are all in. 40% of people stop smoking after a heart attack or a stroke. 25% adapted to a healthy eating. 25% started to engage in vigorous exercise. I think this tells you where we are. I don't think we can go any lower. The only way is to go up, and the physicians cannot do that alone. So I see all of you as leaders in the field. So this communication is not solely directed to you individually. Because you are interested and engaged individuals, I think you have to take this message to your communities, to your workplace, to everywhere that you can engage people. Otherwise, my effort, Dr. Kaparia's effort, others' effort are futile. Talking to 300 people and changing what percentage of 300 people is really not meaningful in a country more than 1 billion people. So you all have to be leaders equipped with this information to take it back. That is the only way that any country in the world can manage financially to overcome this giant expenditure. You know, in the United States, 18% of the gross national product, 18 cents from every dollar that the entire country produces every year goes to the healthcare. And it's only going to increase, because look at this graph. As we age, and if our risk factors increases, the money that we spend increases. I don't think India can afford that at all. Certainly the United States, with all this wealth and income, can't afford it. Same story, I don't want to bore you too much, but it's same story with the medications. Now, when somebody has a heart attack or a stroke, we give antiplatelet. That's the fancy term for aspirin. We give statins. Those are the cholesterol-lowering medications. And we give these other medications that protect the heart. These are all proven in thousands and thousands and thousands of patients. Again, from Dr. Yusuf's work. Look at that. In the low-income countries, there is almost 10% of people are adhering, even taking one medication, let alone 3 medications. Here is another graph that's showing that so many people are not even taking one medication in the long term in a meaningful way. That's again a breakdown of the medical establishment's success. There are many, many patients that get into trouble, are never seen afterwards, and never accounted for. I'm not even talking about the psychological issues, because that's another component of Dr. Kaparia's hard work. We know that when people are depressed, their risk of having a heart attack or general coronary artery disease or dying increase substantially. And in the modern world, with a very fast pace, with a lot of stressors, the risk is really increased to be depressed, or depression become really unmanageable. So we have to be very mindful of that. Now, I want to take a moment for stress, because stress is a difficult thing to measure. Huh? We have stress in our lives. I think that as important as the presence of stress, also the management of stress is important, because we all have stress. I frequently tell this story as far as the management of stress. Let me digress for a second. I do procedures that are sometimes very high risk. So some days in the hospital, I deal with people that are really at the, a few hours to a few days left to live. So when I take them to a procedure, I know that I can lose them right there. So I had one of those days, and the night before I was on call, it was a 36-hour day. I had many, many extremely sick patients. Some of the procedures went well, some others didn't go so well. It was one of those days that you feel when you're going home, everything is taken out from you. I could barely drive, so I was so mentally and physically drained. So I came home, and at that time we had a painter named Pierre, that my wife was having him put in the entry area, put wallpaper. So I said, how are you? Pierre is a very perfectionist, very meticulous, almost like artist-like craftsman. I said, hi, Pierre. It's like 7 o'clock in the evening. I said, how are you doing? How is everything? He says, doctor, I'm dying here. I'm terribly stressed out. My stomach is going to bleed. This is terrible. I said, what happened, Pierre? He says, you can't imagine. Look at this. These 2 wallpapers are not aligned. I paid so much money for that. You know, what am I going to do? So I paused a little bit. I said, and this is a real story. I said, here is a man that's going to have an ulcer bleeding, maybe a heart attack, because these 2 supposedly 2 wallpapers that need to be aligned is not aligned, and his work is not, I can't even see it's not aligned, but it doesn't matter. And I lost a patient. I had several patients in the intensive care unit. It's just a horrible day, 36 hours up. I said, but it doesn't matter. His body feels the same stress that I feel because of my workday. It is the absolute value of the stressor is not that important. So I thought about it, and the stress really is, when you look at that, what is demanded from you and what you can deliver. So we are stressful when we have a high psychological demand and low decision control. Today, for example, I was very stressed when I was going to meet later in the day with Dr. Kaparia, because I was stuck in the traffic out there, and I needed to go. I had a tremendous psychological demand on me because I had to be on time. People were waiting, but I couldn't go because there's no way. I couldn't fly. So that stress is very important. Of course, if you have money and health problems, that doubles, quadruples your stress. But if you have family and friends and support, also from the medical community, I think your stress may be manageable. So I think that we have to think about that. Now, When I finish, I want to bring another thing for your attention, and I think I want you to pay very special attention to this point. Now, you're all aware of the importance of exercise for heart disease, or eating well to prevent heart disease, right? You're all aware. But awareness, unlike many of us want to think, plays a very little role in prevention. And it's shown in here. This bar graph shows, in United States, 30 minutes of moderately intense physical activity at least 5 days a week. The awareness certainly changed after 1986, but the amount of people engaged in that did not change appreciably. So awareness is not enough. In addition to awareness, you have to give the people skills, how to do. Because all of you are not same. Some of you would like maybe to walk, some of you would like to jog, some of you would like maybe to ride a bicycle, maybe some of you would like to do that at 6 a.m. in the morning, the other at the lunch break, maybe the others are when they go back home from work. So it's the skill set that is needed for that should be given. Motivation. It's very easy to say, well, today I had a lot of work, yesterday I wasn't feeling well, and then not doing the chore. But if you are engaged in sometimes in the groups or some other way of motivation, I think it's very important. So this all create an opportunity. So that's why I really credit Dr. Ramesh Kapadia very much, because in addition to his medical side and the spiritual side, he also creates this opportunity by motivating people and then giving them the skills to protect themselves from the heart disease. Thank you very much for listening to me.
Thank you very much, Doctor. Do not store your dreams in your eyes. They may roll down with tears. Store them in your heart, so each heartbeat will inspire you to fulfill them. Thank you, Doctor. गम मुझे, हसरत भी मुझे, हैरत भी मुझे और सौदा भी मुझे. एक दिल देकर खुदा ने दे दिया क्या क्या मुझे. ગાલિબ સાહેબે આજે આ જ બાબતની વેદના ઠાલવતા કહે છે કે मेरी किस्मत ने में इतना गम था रब ने कहीं दिल दिए होते. મારા ભાગ્યમાં એટલી બધી વેદનાઓ હતી કે એ ઝીલવા માટે ખુદાયા એક જ નહીં પણ કંઈક વધુ હૃદય ગોઠવી દીધા હોત તો એક જ હૃદય ઉપર આટલો બધો બોજો ન હોત. एक जिस्म जहाँ पर मेरा रब क्या क्या जख्म दिया मुझे. खुदा समझ लो ऐसे ही बंदे को वो इम्तिहा दे रहा है. एक ना एक हृदय ने प्रेम, લાગણી, ધ્યાન, સવાસનથી સાચવ્યાની કળા એટલે જ યુનિવર્સલ હિલિંગનો પરિવાર. અને રમેશભાઈ 22 વર્ષથી સૌના જીવનમાં આજ એકના એક હૃદયને સાચવવાની સુંદર કળા શીખવી છે. ખૂબ ખૂબ આભાર.
મારા બે પ્રશ્ન છે. મારો પહેલો પ્રશ્ન એ છે કે ભારતની અંદર હાર્ટ એટેકના પેશન્ટો વધારે ને વધારે છે, એનું કારણ શું છે, એનો બાબતમાં એમનો અભિપ્રાય. ને બીજું એ છે કે ઘણીવાર પહેલાં હાર્ટ એટેકમાં અવસાન થઈ જાય છે, જ્યારે ઘણી વખત 2-3 એટેક આવે તો બી માણસ જીવતો હોય છે. તેનું કારણ શું છે? થેન્ક યુ.
You're right. The heart attacks are increasing, and 20 years ago, we used to think that heart attack is a disease of the industrialized world, of the West. But it's sad to see that now the largest portion of people having heart attacks, perhaps 2/3, are occurring in the developing world, like India. There are many reasons. Our way of living has changed. We have constructed cities that are very unhealthy. If you go outside, the stress of the traffic, the air pollution, our eating habits has changed. As we became more motorized, we are much more sedentary, much less moving, much less daily activity. We live longer because we have less infectious disease, other things, so we are exposed to this unhealthy environment. These are all reasons. And also, because of this unhealthy eating, we are getting overweight, and that invites diabetes and high blood pressure. Those two trigger the heart attack. I think you are absolutely right in that regard. As far as the second heart attack, third heart attack, people are still living because we physicians are quite good in minimizing the damage of the heart attack. You're absolutely right. The question is, how accurately a CT angiography report will reveal adequate or reduced blood supply to the heart? Excellent question. Both CT angiography and standard angiography is a photograph of the highway. It doesn't tell you about the function of the highway. There are efforts now underway that CT will give us some what we call functional information. That's number one. Number two, CT angiography's resolution is not as precise as standard angiography's resolution. So we generally give range. We say 50 to 70, 70 to 90% narrow. So I hope that this answers the question. So in short answer, it doesn't give really the adequate or reduced blood flow information. How and why diabetes is risk factor for heart disease? Can you throw some light? Of course. Diabetes, long before it started, in many patients, really shows itself, or tendency to diabetes or pre-diabetes, by what we call insulin resistance. This is insulin resistance. The main fuel of the cells, say in the muscles, is glucose. So many things that we digest turn into glucose to be used as for energy. Now the glucose from the blood should travel to the cells and has to go into the cell, because cell has a wall. So what happens is one insulin holds the hand of one glucose and goes and knocks the door of the cell, and then the door is open and they go in. But if our glucose content, and for some other reasons increases chronically, then after a while the cell says, I can't take you in with one insulin alone. You gotta come with 2 insulin. A few years later, 3 insulin. So that is what we call insulin resistance. That leads in the blood to a higher level of insulin. And higher level of insulin triggers a lot of the mechanisms that I have shown you. It disrupts the surface of the blood vessels. Remember that blue cell slipping in? Normally, in a healthy blood vessel, it's like a very fine ceramic with very good filling in between. Nothing goes behind. With high insulin and other effects, that is disrupted. And the plaque formation is increased. So these all trigger, and we know that diabetes is a very important risk factor for that reason, for growing plaque and subsequently leading to heart attack, because remember when that cap ruptured, there is blood clot forms. Well, if you have high insulin resistance, you have a tendency to form clots as well. So there are a lot of mechanisms. Okay, here we go. Okay. What is the single most important cause of coronary heart disease? Being overweight or high cholesterol? Well, the most important risk factor for coronary heart disease all around the world is age. As we get older, our risk increases. I think number 2 is smoking. Tremendously important. Then being overweight, particularly carrying the weight around, if genetically determined, if you're carrying the weight around your belt rather than your hips, which most of us are, that is, in my mind, very dangerous. because that sets you up to be diabetic, that sets you up to be hypertensive, and that in turn sets you up to have heart disease and heart attacks. And I know that in India, that is more of a problem than simply elevation of the bad cholesterol. Very good question, though. Has vitamin B12 deficiency any role in heart disease? Not this type of heart disease. You know, when you have anemia due to B12 deficiency, that in itself can cause problems for the heart because of overworking heart and so forth, but not this type of heart disease, which is the most common. Diabetics suffer from silent heart attacks. How can one sensitize this? How can one sense? Excellent question. Very, very smart questions. Let me just give a broader view about this question. The question is, people with diabetes have silent heart attacks. How can we pick it up? Most of our information in mid-50s, 60s, and 70s about heart attacks came from middle-aged white men. And then the classic picture is somebody holding his chest, having chest discomfort, going to the arms, going to the jaw. Well, we know that a good 30 to 50% of people do not have these classic symptoms. Particularly women may present to the doctor. Sometimes they say, I have never felt this bad. I feel horrible. This is the worst I have ever felt. I can't lift my finger. Profound fatigue and feeling bad. Immediately think about a heart attack. They may just come with nausea, extreme nausea, feeling bad. They may come with syncope, passing out, as a heart attack sign. A good 20 to 30% of the heart attacks found accidentally years later. If you inquire, some of those people say, yeah, 6 months ago I had a very bad cold. You know, I didn't have fever or anything, I didn't cough, but I felt so sick I couldn't go to work 3 days. Then afterwards when I went, I was still tired. So what I'm trying to say, yes, there are patients that don't feel anything, but most of the time, the atypical, what we call symptoms, fatigue, nausea, feeling fainty, these are all should be taken very seriously in the right context, of course. Alternative therapies like chelation and or EECP, how good, safe, and proven they're in America? Can this be considered for patients with blockages and chest pain? Now, very good question. Chelation therapy is very, 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 very controversial. There is one trial that showed a slight benefit presented last year and created a lot of controversy. I would not really go with chelation therapy in my mind. I think that most of the evidence is against it. EECP has proven to alleviate the symptoms quite effectively, but it's a laborious process. So this is EECP is we put big, huge blood pressure cuffs to the arms and to the legs, and in synchrony with the heartbeat, we pump the arms and the legs so that we change the blood flow back to the heart. That works if there is nothing else that can be done. If you have a lot of chest pain that will require EECP, I think there's a time for angiography and see what can be done. But other than that, I think that EECP is we have an EECP system in our hospital, for example. What are the opportunities for healthcare service providers to spread awareness of prevention and treatment of heart attacks? As a medical tourism facilitators, how can we engage more and more people for alternative medical opinion? Okay, two very different questions. Let me answer the first one. What are the opportunities for healthcare providers to spread awareness and prevention and treatment? Now, I think there are many, many avenues. One of the most effective avenues is engage small children, school children, because it has two advantages, two really wonderful things. First, you can get into the young mind for a long-term effect. If they engage in healthy eating and then the active lifestyle when they were 6, 7, 8, 9, 10, there's much higher likelihood that they will keep it in the long run. But as importantly, that if you engage the young child, they will be effective in changing the lifestyle in their families. The 8-year-old kid will have much more chance to have his father stop smoking, or to have his mother cook better, or to get them engaged in exercise. And this is not only opinion. There are studies now done in South America and in Spain that looked at they divided the kids into 2 groups. One group of kids were given special education. They were given cooking classes. They were shown the effects of smoking. The other group of kids didn't have that education. There were marked differences between the change in the family's lifestyles in the 2 groups. So I would encourage that if you are serious about this, start there. That's probably the more efficacious. As a medical tourism facilitators, how can we engage more and more people for alternative medical opinion? Now, that is a whole different kettle of fish, as they say. First of all, medical tourism's purpose is really to get patients to the hospitals, generally for procedures. Right? People come to you, say, if they come from Poland or from England to India, they come for hip replacement, knee replacement, bypass surgery. Predominantly, it's good, it's safe, but most importantly, it's cheap. Now, there are people that are going outside the United States because now we are all so expensive. So I think that to do this, India probably is in the best position of the alternative. I don't like to use the term alternative because that means that modern medicine is bad. Dr. Kapadia's success is because he did not deny at all the capabilities of the modern medicine. He complements them. So I think that what you can do maybe for marketing is for people who are coming for those procedures, you can say, hey, this is not all about your knee or all about your heart. There is some other aspect of this thing, and we can provide that with this holistic approach. How effective calcium cardiac score is for diagnosing of heart condition, and when angiography is necessary for diagnosis? Excellent question. Calcium scoring is getting a special X-ray of the heart and seeing if there are any calcium deposits on the blood vessels. Simple as that. Because we know that the 99.99% of presence of calcium in the blood vessels in the heart means that you have the disease. And if you have the disease, you have to be more active in taking care of that disease with all the things that we have told you about. Now, the problem is, we used to think that if there is nothing on the calcium scans, you're absolutely home free. That is probably not the case. So if somebody comes to you at age 55, smokes 2 packs, his cholesterol is out of control, his high blood pressure, and his father died at 45 because of heart attack, if calcium score is negative, I will be very nervous to say, oh, you have no problem. Having that caveat, I think calcium scoring is a very good tool. When to have angiography, you really have to have symptoms that are pretty bothersome, that is not controlled by the medication, and or you have evidence of inadequate blood supply to a good portion, 10 to 15% or more of your heart. Those 2 things require angiography. Why? Because those 2 things, if they are corrected, you are better off in the long run as far as survival is concerned. So don't get angiography for screening. Don't get angiography for if there is no substantial reason for that, because that's a slippery slope. You get an angiography, you say you got 80% narrowing, you need a stent, right? That's a common scenario.
I think, shall we stop there?
Okay.